vision, but I want to take this opportunity to share with you one of the age-old projects, that presentation that I had in my collection, and there's a good review of echophysics as well as echo artifacts. So without further ado, I'm going to start. My name is Chi-Ming. I'm echocardiographer, cardiologist at St. Michael's Hospital, and here we go. So the objective today, we're going to talk about the basic ultrasound physics that lead to echo artifacts, to review common echo artifacts that are encountered in day-to-day clinical setting, as well as to challenge participants, which are you, with echo artifact cases, and see if we can figure it out. So feel free to type it in the chat box so we can follow along and see what you think. So recently, one of my mentor, Dr. Bob Levine, was here in town as a special speaker at the Canadian Society Echo 2025 in Toronto. So it's great to actually run in back to him. It was wonderful learning from him when I was in Mass General. And the way he looks at things is very different. So I learned a lot from him. And often the fellow in my generation, we called our Echo Fellowship a pseudo fellowship, because every week or every month we would come up with a sign that we call Pseudo-MR or pseudo-wall motion abnormalities, etc., which you're going to hear more about. So I want to dedicate this particular presentation to Dr. Levine. Is also the author or originator of the idea of the scallop shape of the mitral valve, as well as pioneer in 3D echo and much of the valve repair or devices. Actually, the original concept came from him as well. So want to share with you about Dr. Levine, whom we call fondly Bob. Okay, so just want to bring you another favorite topic of mine, which is Sherlock Holmes. And Sherlock Holmes said in the book, "Watson, you see, but you do not observe." So this is an interlude to see what the audience know about Sherlock Holmes. So anyone know who actually wrote Sherlock Holmes and what he does as a day-to-day living? Feel free to speak up or type in the chat. Hopefully this is very participatory. Anyone? Okay. So let's move on, and here we go. So this is the author of Sherlock Holmes. He's originally actually from Edinburgh, and his name is Sir Arthur Conan Doyle. He was born in 1930, and he's actually a physician, as many of you may or may not know already. And he, as a hobby, he would actually write about detective stories and fantasy and science fiction during the weekends and evenings. And he spent a lot of time actually observing what his mentors would do with the power of observation, and looking at patients and deducing their medical conditions and findings. And he put himself as Dr. Watson. So that's why there's a Dr. Watson next to Sherlock Holmes. So that's Sir Arthur Conan Doyle. So every day, when we are reading echoes or actually seeing patients, we apply our power of observation. I think, as a technology guy, I still very much pride on the fact that as physicians, we actually use our power of observation to actually help our patients. There's certain things, even with multimodal artificial intelligence, it may be quite some time before these are actually acquired by the technology. So let's move on. Definition of artifacts. So the bottom line is any artifact is any structure in the image that does not correlate directly with true anatomy. There are errors in imaging, for example, perceived object that is not real, true anatomy that is not displayed, structural location that is misregistered, improper brightness, improper shape, or improper size. So the causes of artifacts could be because of violation of assumptions for 2D echo mapping. There's equipment malfunction or design, miscalibration, faulty crystals or probe, etc. For those of us who has been in the field for a long time, way back when echo machines were developed, we actually have to bring a technician. They have a phantom that actually calibrate with a certain amount of alcohol and distilled water, I guess, to create a certain density in the fluid, so they can make sure that the calibration is correct. Interestingly, at least for the last 15 years, there's been no need for that. I think the machine actually figured it out all by itself, so we don't see a calibration technician going around to each of our machine calibrating on a regular basis. But miscalibration was one of the major problem way back when in terms of measuring distance. There's also issues with operator error. For example, too much gain, too little gain, improper TGC setting. And for echocardiographer, TGC is a very old term called time gain constants. It's basically the vertical ports that actually are available on your machine that is either physical or mechanical or electronic on your system, to actually calibrate the brightness on each of the level of your echo images. And it's called time gain constants because it's the distance and time, which is the the essence of echocardiography. There's also, last but not least, the interpretation error, which is due to anatomical pitfalls. For example, we're seeing things that are misregistered, and we think that maybe aorta is really, something else, another structure in the body, for example. Okay, so some of the basic assumptions of 2D echo mapping. So this is a very important point about what we do in echocardiography. This is the basics. Anyone who is involved in Echo 101 on the first day, these are the things that we tell them about. And the sonographer, you learn that from your sonographer school. So number one, sound travels in a straight line path from the transducer to the reflector and then back. So it goes straight and comes back. So it shouldn't actually take a detour or reflection or whatever. So that's the assumption that the echo machine is actually making. All the reflected echoes arise from structure that exists only along the transducer main axis. Okay, so just along the main line, so it doesn't go sideways. Sound travels exactly at 1540 meter per second. So this is actually something, if you are taking an echo exam, this is something that you should know about. 1540. This accounts for the air, the fluid, the bone, the tissue, and everything else that an ultrasound would encounter along the way. So that's the average that everybody should know, 1540. If someone wakes you up in the middle of the night, if they ask you, what's your wife's birthday or your spouse's birthday, you have to know that. And also 1540 meter per second in terms of the sound speed in human ultrasound. And then the other assumption is the intensity of the reflection produced by the structure is directly proportional to the scattering strength of the reflector. And also the beam dimensions are infinitely thin in both section thickness or lateral dimensions. So in general, artifacts appear and disappear depending on the view. So if you see certain things that are there in one view, like for example, a mass in the left atrium, if you see in parasternal long axis, but then if you go to apical and then you keep panning, you don't see it, then it's likely that the image or the shadows that you see in parasternal long axis is likely an artifact. Okay. The other concepts about artifacts is that it disappears when corrective measures are taken. For example, you have too much gain, you decrease the gain. If your PRF of your color Doppler is set too high or too low, if you actually fix it too correctly, you can get rid of it. And so those are some of the corrective measures that you would do as a scanner to actually try to interrogate and try to detect whether this is an artifact or not by changing it. Now, despite all that, after you change the view and then you do all the corrective measures by changing the gain or PRF, the actual anatomy still remains. Okay, so if it's real, it's there. If it's not real, then you can get rid of it or see it another way. Okay, so then there's also instrumental problems that will remain despite changing imaging angles. So, for example, sometimes way back when we would have crystal problem on the probe. So one line will be completely disappear. You'll be scanning like a fan, but then one line will always be a problem. And that's instrumental problem, so you need to talk to your vendor to try to fix it. But I think these problems are much less in occurrence now, because the thing is so sophisticated with so if it actually breaks, the whole thing breaks down. So it's just nothing. So as opposed to be all these weird structures. But it doesn't mean you have to be aware of the instrument that you use that can cause problems and artifacts. Okay, so now the next step is a menu, like you're going to the restaurant, the types of artifacts that you may encounter. So these are the things we're going to talk about today. I won't go into each of them, but for those of you who are preparing for an exam, either in sonography exam or you are in a echo exam, then you have to know about these things. And often, when we discuss about cases or when we present, we see things that are not there. We'll try to attribute to one of these types of artifacts and see if we can explain what you see. So for the remaining of the studies, let's try to make it interactive. And if you have access to your keyboard, if you're driving, don't do that. But if you have access to your keyboard, or if you can unmute, you can shout it out and then see if we can help me to figure out these cases as a detective, like Dr. Watson and Sherlock Holmes. Okay, so case number 1, let's see, there you go. Okay, so I need help. So anyone online who can help me? I'm going to look at the chat box and see if someone is actually typing it in. So what are we seeing? Which view are we looking at? Okay, it's still very quiet today. I hope you're actually listening. My voice is okay, and you're listening to my presentation. Someone can type it in if you can hear me. Okay.
We can hear you fine.
Thank you, thank you. Okay, so help me out here. Oh, very good, very good. So thank you, Rhonda. So it is a suprasternal view, yes. And what are we looking at structure-wise? Yes, aortic arch. Thank you, thank you. Now you're participating. Again, this is all participatory. So I need your input in doing this kind of virtual rounds. So yes, so what's wrong with this?
It's a color mirror artifact.
Thank you very much. So as many of you know in the Echo Lab, this is one of my favorite artifacts. It is like, okay, so this is, let's identify the structure. Just make sure I have my arrows. So here, the pointer, you can see the ascending aorta. This is the aortic arch, and this is the descending aorta. Okay, well, what is very unusual is actually this color jet here. And because it is outside, so we know human beings do not have two aortas going side by side going down, right? Unlike Klingons, for example, because Klingon has multiple hearts in Star Trek. And for this is only for people who actually are Star Trek fans. But here you have a color Doppler that is actually going forward and another color Doppler going forward. So, but you probably see it. I mean, now that I pointed out, for the rest of the day, go and look for it. You probably will see it in about 40 to 50% of all your cases. This is actually what we call a reflection artifact, or called double aorta artifact. So you all know that this is not real because you know the anatomy. That's why your brain automatically filtered this out. But this is very convincing because sometimes, like, when you're looking for things and your brain suddenly click into it, and then you would start pontificating or wondering what this is. So this is called a double aortic artifact. So or the mirror artifact. So where is the mirror? The mirror is actually the far side of the aorta. So what happened is when the ultrasound comes in, it insenates there and then actually like detect the flow differences in terms of velocity. But it also hits the wall as a mirror, reflect this way, and then come back and goes back up. So this is actually a very common artifact that we see, and we noticed that depending on the insonating angle between the probe and the wall, if this is actually less than 45 degrees, then the reflection is actually there. If this line here, or the far wall of the descending aorta, is more vertical, more than 45 degrees to the the main axis, then the artifact is gone. So it's really depending on the mirror. Just like when you go into like a mirror house in an amusement park. So let me see if I can go to the next one. So this is actually the diagram that I've drawn for creating the artifact. So again, this is the far wall of the aorta, and the insonating sound actually comes in, goes and hit the object, and then it comes back and reflected back up. And then because the sound doesn't know that it's actually travel at a right angle or travel at some angle, and then this particular signal is actually reflected over here as if actually gone forward and go in a straight line. That's the assumption that we talk about. This is a double aorta artifact. So for the next day or 2 or 3 or 4, go and check it out, and you'll find it actually fascinating. By the way, these images was obtained when I first arrived at Sigma 2000, and it still actually looks pretty good after all these years. Okay, again, this is the double aorta artifact. This one of the first generations GE's Vivid. Okay, so next one is a little bit different. So technically a little bit difficult, but this is actually the 4-chamber view. Left ventricle is here, left atrium is here, right atrium is here, and the atrial septum is here. So what kind of artifact is this? Feel free to type it in or shout it out. Oh, actually, this is the artifact I was going to show you. That was the mechanical mitral valve, but this is the artifact I want to share with you. So sometimes what happens, what is really fascinating is that, you have the left ventricle during systole, there's a color Doppler here, right? So what do you think this is real? Because, it's really, like in your mind, you will know that this is called what we call the dark side of the moon, because during systole, the mitral leaflet, the mechanical mitral leaflet will be closed, right? So you shouldn't be able to see beyond the mitral leaflets, and you can see these like reverberation artifact, or what we call comet tail, that's actually keep coming down because like you just keep reverberating here. But what is this color thing? Are you worried about? Oh, thank you for the mitral valve in the chat. So what do you think about this color Doppler? Is that real? Is this like, perivalvular leak? Is that intravalvular leak? What's going on here? Or is this real? Anyone from the chat? Don't jump all at the same time. Okay, good. Thank you. And this is not real. Good. Do you know why this is not real? Is that because that is the dark side of the moon? You're not supposed to see it? For those of you interested in astronomy, because of the rotation of the moon and the Earth, there's one side of the moon that you can never observe supposedly from the Earth position. That's why there's been a lot of discussion in the 1960s, and that enemy states has set up station on the moon. That's why the U.S. people send up the Apollos to go and check out the back of the moon to make sure there's nothing there. But this particular interesting sort of theory actually get replayed out in Transformer, in one of the movies about the dark side of the moon. So if you haven't seen the movie, you should check it out. So it is, these are comet tails, so thank you very much. But the color Doppler is a type of artifacts called pseudo-mitral regurgitation. So again, going back to the theme of my pseudo fellowship. So again, when you PW that color Doppler jet, which you should, by the way, for in the future, in case you are looking for it, you see that it looks really funny. Okay, so it has an opening click and a closing click, and then it looks kind of funny. It doesn't look like MR. What does that look like? It looks like V1, right? So here I put it side by side. This is V1 PW of the LVOT, and then you can see that when you put it side by side, that color Doppler that you just saw in the left atrium is remarkably similar in terms of velocity and also the shape as V1. So why did the V1 actually occur? So this is actually a paper that was written by Dr. Lawrence Rusky, myself, and also Dr. Bob Levine as a senior author way back when we were doing our fellowship. It's called the Pseudo-MR, and it's really an reflection from the septum. So again, when we actually insonate the beam that comes, some of the flow will try to go through, which you can't because the valve is closed. But what happened is it get reflected at a certain angle and then caught the LVOT flow and then comes back and then reflected back. But again, the ultrasound doesn't know better if things are supposed to go straight line. So this particular flow get mapped out over here. And that's the reason why you have pseudo-mitral regurgitation. And you'll be surprised to say, well, look, we know that it's an artifact, but you'll be surprised to know that way back when we actually did a lot of TEs because of this. So, with the understanding of these artifacts, we actually saved a lot of the TEs. And again, the caution is that if you do see these artifacts of color Doppler where they're not supposed to be, you have to think of what we call multipath reflection or reflection artifacts. And you should PW whatever is in here to actually check out the waveform. So that's one way to actually make a diagnosis of pseudo-mitral regurgitation to save on people having TEs unnecessarily. Okay, so moving along, so another case. Again, this is actually in my first year or so of my being at St. Mike's. These are some of the old studies, but the quality is still pretty good. So, what are we looking at? Let's see. This is, again, a transesophageal echo because you get the omniplane indicator. So what's wrong with this? Is this normal? Thank you very much. It's a TEE. Thank you. Thank you for all your participation. Love it. And what are we looking at? What are these lines inside the aorta? Is that normal? Is that abnormal? Should you panic? By the way, this is in the descending aorta, right? As you turn to the back, as you pull out. So these are obviously not normal. These are like dissection flaps, right? You're not supposed to have lines inside your aorta. It should be nice and smooth and black inside and, nice and round and not so big. But this is actually dissection flap. So this clearly you get something called Stanford type B dissection, which is like in the descending aorta, distal to the left subclavian takeoff, right? Okay, so we put in color Doppler. This is actually now a little bit further down in the abdominal aorta, about 40 to 45 centimeters from the mouth with the TE. And then you can see, there's flow that goes in and out the true lumen and the false lumen, and there's a fenestration that's communicated between the true lumen and the false lumen. The way you tell it is actually during systole, the true lumen actually expand, and during diastole, it goes the other way. So that's how you can tell. You can put a M mode around and see that. Okay, this is actually the long axis. Again, you see the fenestration that goes between the true lumen and the false lumen. Okay, so why am I showing you this? It's because when you pull up to the aorta, okay, now it's the proximal ascending aorta. And again, remember I just started my training as, actually not training, but my junior staffhood. And this is about a year in, and I'm trying to impress all my colleagues that I actually know how to do TEs. And this is a case that we got called in on the weekend. So now you get, type B dissection. Do we have actually type A dissection, which is like involving the proximal ascending aorta? So this is actually a pull-up of the 90-degree views of the proximal ascending aorta. And clearly, you can see there's a line here, right? Okay, so, what do you do? So do you call it a dissection? Thank you. Yes, someone says M mode will help. Definitely, very smart, very smart. You have seen this lecture before, maybe before. And but it's very good. So one of the strategy, what you can do is actually put an ammo here. And I think what you're trying to say is you can see the motion, whether it goes up and down and together. So again, another interesting observation is that if you look at, the distance between, your proximal, chest wall structure to the proximal ascending aortic wall and to this artifact, interestingly, is exactly the same. Okay, so let me show you the MO as you have discussed. So, okay, so now you can see, this is the proximal ascending aortic wall, and you see when there's a bump, right? And when there's a bump, there's a bump. Okay, so remember one of the definition of a flap is that it should move independently of the underlying structure. So a dissection flap should actually move like quite freely, and it should be irrespective or not in association with the proximal ascending wall or the distal ascending wall. So this is actually a very useful tool to use the MO to see whether it moves along. So clearly there's likely a reflection artifact. So most likely what happened is that there's a chest wall structure gets reflected back onto this being a mirror. And then when the mirror moves, then the structure actually appears. So whatever there is actually there. That's why that's the mirror, and that structure get mapped over here. That's why there's a bump, there's a bump. So this is actually one of the useful methods of telling whether this is an artifact or not. Another strategy, which is putting color on it. I don't think I have that picture here, but this is actually the reflection artifacts that has been described. Again, I was borrowing one of the slides from Dr. Levine and showing you, if you have the TE and then like structure can actually reflect it back. In this case, it's the left atrial wall that get reflected onto the aorta, creating an impression of a pseudo-aortic dissection, like going with the pseudo theme today. Okay, so that's another sort of idea that structures can actually map into the aorta, and then like or the aorta can actually map into the left atrium and creating like things that you're not supposed to be there. Another method is actually putting color Doppler here. If you have color Doppler here, and if it's a dissection flap, the flow should respect the artifacts. If you have color that actually just flow through your artifacts or your line and doesn't respect the true lumen and false lumen, then it's very unlikely this line is actually truly a flap. So fortunately, this actually predated the CT scan. So I made the right call. So that is an artifact. So I'm still working at St. Mike's. That was that story. Okay, so moving along, this is another artifact. So this is actually the peristernal long axis. Okay, identifying the structure. This is the aortic valve, aorta, left atrium, mitral valve, and left ventricle. So what's wrong with this thing? Anyone? Is that normal? Is that abnormal? Okay, so I'll just help you out here. So anterior septum is contracting very nicely. What do you think about the posterior wall? Is this a normal contraction? Is that weird or?
Pseudo-dyskinesis?
Wow, who is that? That's nice. Thank you for calling it up. This is, again, one of my favorite diagnoses because we do see it. And we still every now and then see it among some interpreter and also sonographers calling posterior or inferior lateral wall motion abnormalities. But what is really important to note is you focus your eyes on the contraction of the wall that's actually thickening, right? So the idea is that if it thickens more than 50%, normal should be more than 100% in terms of thickening, then it's actually normal. And when you look at the base, the mid, the apex, everything actually contracts. However, during diastole, there's a structure here that's actually inferior underneath the diaphragm that causes the mid part or so, or proximal part or so, that actually doesn't go back to the flattened state. It actually gets popped up. So this is actually exactly one of our colleagues said here in the audience that this is called pseudo-dyskinesis. Again, going with the pseudo theme. This is the short axis. You can see this is actually like sometimes fooling people because when you have like all this contracting and during diastole, it's still contracting, by the way, the inferior and posterior, but during diastole, it becomes a D, right? It's all flattened out. But just remember, this is the diaphragm, and there's often a structure immediately underneath the diaphragm. So the cases that we have seen with pseudo-dyskinesis is, and that's another diagram, depends on where you are, where the structure underneath the diaphragm is pushing up. It can be on the inferior or posterior inferior septal side, or sometimes actually in the posterior or lateral side. So, during diastole, it flattens up, during systole, it rounds up. So, again, the informatic structure could be a number of things, including we have seen it most commonly with hernia or hiatus hernia. One of the ways to make the diagnosis is actually getting them to drink some fizzy drinks. So it could be like, soda or whatever, sparkling water, something. Then you can see the bubbles appearing in the hiatus hernia. And I've done that when I was young. It's really quite fun. Yes, thank you for our audience saying the soda water. Yes. So that's why, way back when I would actually run down and get a soda pop and image in and see, because you can actually see it. And then the other thing that we have seen is actually pregnancy, when, in later trimester where, the baby is actually abutting the diaphragm, pushing it up. The other thing that we have seen is actually peritoneal dialysis. So when you have peritoneal dialysis, especially when the fluid's inside, it pushes up the diaphragm, so creating pseudo-dyskinesis. So anything that, have a large abdominal structure, we've seen it like with tumors, for example, of huge livers and, take up space. So those are the things that you can, see and, try to call it out. So thank you for all your participation today. Love it. And so now we're going to chat about other artifacts. So there's reverberation artifacts, which is multiple echoes appearing on the display as a result of ultrasound bouncing between the two reflectors. Sometimes they're in parallel, sometimes they are not. And the characteristics is there are multiple, there's multiple of them, often equally spaced and parallel to the sound beam, like along the sound beam. So one of the ways you can imagine about this particular artifact is when you walk into the an elevator, they sometimes have mirrors, right? So you can, fix yourself up before you go and have your meeting and etc. But when you have two mirrors, you have like infinite number of heads, right? Going along in your image. So when I was young, I was in a barber shop, which my favorite barber shop that my father would bring me. And in that barber shop, I remember very nicely that, there's two sides, a long, like, hallway or whatever that's in the barber shop. And there are mirrors in every single seat. So I would actually spend a lot of time during my haircuts moving around. And obviously my barber didn't like me, but it was really fun seeing like a million heads, that goes infinitely. And by the way, there's a famous Japanese artist that has the infinity room that took advantage of this. You're going to see one is actually in Arts Gallery of Ontario, in close to our hospital. So again, this is what we call an onion ring artifact. That is a reverberation. That could be part of it is like mirror of the apex that actually goes into the apex here, and there's multiple lines. They are equal, and some of it could be just reverberation and reflection. So what here is also reflected here. So this is very confusing, right? I mean, sometimes it causes concern about being an apical clot, and echo contrast would be helpful in this case, as you can imagine. Okay, so someone mentioned about comet tail and ring down artifacts before. They often appear as a solid line, directed downwards, and otherwise known as merger reverberation. And this characteristic is often single and as a long echo and parallel to the sound beam. So the idea is rather than having two reflector like the one before called reverberation or multiple reverberation, that the sound actually bounces in between this structure, because there's a near field structure and a far field structure, and the sound beam just keep bouncing inside, and then like you create this long comet tail artifact. And this is a very common artifact that we will see. Like I've shown you one already with the mechanical mitral valve. So they're like sewing rings, and it just keep bouncing inside and causing a comet tail. So you see that a lot. Okay, and then shadowing is another type of artifacts that we see all the time. It occurs when ultrasound beam is unable to pass through a structure, and also any structure that lies deeper than the initial image or displayed will not be able to see or to be seen. Sound cannot pass through the proximal structure because it has a higher than usual attenuation rates or major scatterer of ultrasound. For example, the left atrium distal to the mechanical mitral prosthesis. Like, you have seen that in my last example, and this is actually what you will see, right? So you have a mechanical valve that is in the mitral position, and then you can see when the valve close, it causes a comet tail as well as shadowing as well. So anything, this is a problem because if you have mitral regurgitation here, you'll be missing it. But if you have mitral regurgitation that goes further than that, for example here, then you will be able to see it. So for example, you are wondering about mitral regurgitation in transthoracic, then what you can do is, in parasternal, you can angle differently to try to see if you can see mitral regurgitation either around the ring or inside the mechanical valve. So that's using alternative views that you'll be like tilting forward and backward within the left atrium, and so on and so forth. But with this shadowing in apical 4-chamber view or apical 2-chamber view, in the left atrium you shouldn't be able to see anything. So that's something that just keep that in mind. But in the subcostal, you should be able to see that as well. So those are all the different ways. This is actually the shadowing I was telling you about. You've seen this picture already. So that's a left ventricle that is kind of small. The left atrium is super large, but anything along this line, apart from like the comet tail I show you, you really shouldn't be able to see any mitral regurgitation or any like mass in there because it's shadowed. Okay, so you already like experienced some mirror image already today. Sound bounces off a specular surface in the path, and ultrasound system assume the sound travels directly to reflector and back to the transducer. And the characteristics is usually it creates a second copy of the true anatomy, and the copy located deeper than the true anatomy. Mirror lies in a straight line between the transducer and the artifact, and this distance between the true anatomy and the mirror should be equal to the distance between the artifacts and the mirror. Simple physics that you have learned when you were in high school. So this is actually the schematics, and you've seen that already as a double aorta. The other very common features is actually a mirror artifact in a parasternal long axis. So let's see if this thing moves. There you go. So you see the mitral valve here beyond the posterior wall or the pericardium. The pericardium is a specular reflector. So the difference between a specular reflector and not is when a specular reflector is like a mirror, that the undulation or the particle size is smaller than the wavelength. That's why it can actually, reflect the images. If the particles are rougher, for example, like a drywall or stucco wall, where light comes in and it keeps bouncing all over the place, then you actually can't see your face in the when you're looking at the stucco wall. But when you have a mirror, for example, a very sheen plastic or your iPhone surfaces or actually a mirror, then you can see because the surface particle is so small, then it can reflect. Like often way back when it was actually done with mirror, mercury, for example, as a way that is impregnated in the glass, but now it's not a good idea. And then way back when you have like in the prehistorical time, you've got like polished copper as a mirror, etc. But here, you actually can see the specular surface of the pericardium becomes a mirror. So when you insonate from above, and you see the valve obviously, and then it goes beyond, and then reflected back, and then that's why you have a copy of the mitral valve beyond that. So I think because human beings, in reading echo, your brain knows that you don't have two sets of mitral valve, so automatically your brain filters that out. But sometimes there's structure that get reflected gets very confusing. For example, whether there's like pleural effusion or some other mass outside. So just keep that artifact in mind and the physics that goes with it. Again, we show you this mirror artifact. One of my favorite mirror artifact is actually double aorta. Check it out and see how often you see this. There are other propagation speed errors that you can see. For example, the ultrasound system assume the ultrasound travel in the tissue, combining our muscle, our joints, and our air and fats, and that equals the total of or averaging 1,540 meter per second, 1,540 meter per second. I keep repeating because that's the number you have to remember, especially when you're planning to take your exams. The incorrect depth of the reflector on the display, if this assumption is violated. So, for example, the calibration is incorrect, and that could be a problem. But the good news is we don't necessarily calibrate it anymore. I did try to ask the ultrasound vendor about why they don't need to calibrate with the phantom anymore. Because when we were young, we used to do studies on phantoms by looking at the lateral reflection and the lateral resolution on ultrasound and things like that. But they just say like we don't do that anymore. Okay, so then there's also refraction issues. So, for example, sound changes direction when it strikes a boundary obliquely, and when the media have different propagation speed. A second copy of the reflector is placed on the image side by side of the true anatomy. So this is actually like equivalent to putting in this is equivalent to putting in a pencil like through the water. Some like one of the physics thing that you learn when you were in high school. So that the true anatomy should be here, but because the media is of a different density, then you actually see the anatomy as a different location. So this is what we call a beam spread artifact. So when you have a very bright structure, because the beam is not infinitely small or thin, because it's a bright reflector, it gets actually mapped out to the side, usually laterally, and it moves up and down with the structure. So that's the way to tell it. And this is otherwise known as the side lobes or the gating loops. And because acoustic energy may be directed in regions other than the beam main axis, a second copy of the reflector is placed on the image side by side of the true and anatomical structure. And then also the mechanical or single crystals can create side lobes, and array probes, which is what we're using, is called gating loops. So this is actually what the ultrasound looks like, as opposed to be, insulated in the main axis. Because of the constructive and destructive interference, you actually get other structures that are on the side. The good news is with the harmonic imaging, we're able to amplify what is in the second harmonics to be able to eliminate all these side lobes. So what you do is you do not read the fundamental imaging, but instead you take the second harmonic imaging, which is weaker, but then you can actually amplify this to actually make it back into the big one. So in this way, if you actually read only the second harmonic echo signals, then you're able to actually get rid of a lot of side lobes. So if you look at the pictures from before the 1990s or 2000, when fundamental imaging was the main way of doing things, versus after 2000, where pretty much every single machine now use second harmonic imaging as the fundamental way of doing things, then we're able to get rid of a lot of the side lobes. So that particular PMAC that you saw was actually a side lobe artifacts. There's also issues of slice thickness, because then when you see certain structure is supposed to be this thick, but then it can become a lot thicker, and because of the slice thickness, because the beam is not infinitesimally thin, so it has actually some width to it. So that's also coming to the discussion of resolution. That's in the main axis as well as laterally. And then there's multipath reflection, and which I'll just show you, because structure can get very confusing, because you get multiple reflective surfaces inside the heart. So then image. So you sometimes have to use imagination to try to figure out where the reflection actually occurs from, or the reflectors are from. And then there's also a concept called temporal resolution. It's the ability to determine a reflector's position in time. And temporal resolution is best with high frame rates, and with the newer machine is much better. With 2D, we're now able to get up to 60, 70, 80, 90, 100 frames per second. When we were a lot younger, they are like, 16, 30, 32, that type of thing. So, really, even with very fast moving structure, like a young heart, and we are now able to capture the hearts with a much higher resolution than before. Again, higher frame rates occur with shallow depth and lower line density. So, if you want to increase your temporal resolution to capture things that are moving very fast, you can just narrow the sector so that when it travels back and forth, it's a lot faster. You can increase the frame rate, and that's how you can capture. And you can actually move the sector as well. You want to look at things that are on the side, you just make the sector smaller and then just move it to the side. And then for that particular area, then the temporal resolution is a lot bigger. Because the problem comes when you're doing color Doppler, because when you're using color Doppler, when your color sector is actually fairly big, and then it takes a lot of time to calculate every single pixels. While in 2D, it keeps moving at a faster rate. So sometimes your color Doppler actually gets spread over to, like, from the left ventricle to the right ventricle side, for example, or it maps from like one chamber to the other. So again, keep thinking about narrowing the sector when you're having very fast heart rate. That is, keep refreshing. But still, remember to make sure that your color sector actually covers the receiving chamber so that you don't miss any regurgitation lesions, etc. There's also spatial resolution, and then the concept is really, if two structures are closer than either the lateral resolution of the ultrasound machine, they will appear as one. So rather than two tiny little things and then it merge as one, just like, when we're getting older, our eyes are, getting more difficult to look at things, and then like things become much more fuzzy. And there's also noise as well, and the noise can appear as very small amplitude echoes and resulting from electrical interference, and also the ultrasound processing can be troublesome, and then also can have spurious reflections, and noise likely to affect low-level echolucent areas rather than bright echo areas. So again, turning the gain is very important. We used to have another button for compress, which is looking at the grayscale. So, excellent sonographers or image catcher will be able to tune that so that you have got really wonderful pictures. Again, enhancement in structure appears to be brighter than normal, occurs when medium, through which the sound travel has a low attenuation rates in the soft tissue. And since the attenuation rate is less, echoes returning from a deeper areas have a higher brightness on the display. So again, these attenuation, if you have too little, then you have extra echoes on the scan, and then often they're parallel to the sound beam and deeper than the attenuator. Okay, so I'm going to stop here. It's 8:52, and I hope that was meant to be comprehensive in terms of going through all different artifacts. And any questions or comments, please put in the chat. This particular set of presentation is actually very useful for preparing for echo exams, for example, the National Board of Echo Exam, as well as for sonographers to prepare for your sonography exam, because this is part of the extended physics that we will talk about, because of the art of interpretation. Art of interpreting echo is an art of interpreting artifact. This is actually from Dr. Levine. I quoted.